We're going to talk about a drug that I've been using now for 20 years, ketamine. How many of you use ketamine in your practice? How many use ketamine as an analgesic? A few. How many of you are cursing the gods of administration because they won't let you use ketamine as an analgesic? A couple. All right. So I'm not going to tell you anything new then if you're already using it. Maybe we'll go over a few points. What's remarkable is this drug first came out in the 1950s. It's been a generic drug since 1964. And at the last two World Congresses of Pain, which happen every 2 years, it's been the #1 research drug in oral presentations and abstract presentations as a generic drug. It's the only generic drug to have ever been that much studied 30 years after it lost patent. So this drug is being studied in all sorts of ways. What's really scary, I don't know if you're aware of this, is that the WHO considered at length this past 8 months to make it a restricted drug, which is really scary because in many countries around the world, it's the only anesthetic available for general anesthesia. It's the only medication used for procedural sedation. So there was a huge push by the International Federation for Emergency Medicine, by other organizations to prevent that from happening. But apparently China was the biggest country pushing to get it restricted because of the amount of abuse of ketamine in China. But last week, the WHO agreed to put it aside, and so it's not going to be a restricted drug, and it's still going to be available for use. So when did we know that ketamine was a good analgesic as far as emergency medicine is concerned? It was 1996, the first study published that was out of India, and it showed a remarkable sequence of events. This was a study that used a very low dose of ketamine, 0.1 milligrams per kilo, as in subcutaneous infusion in ICU patients. And it showed the need for morphine was reduced, that the duration of stay in the ICU was 24 hours shorter, and the respiratory complications were reduced by 50%. And that's why nobody in North America chose to use the drug. It tasted great, it was less filling, it was inexpensive, and so no one used it. I happened to have read the article, and 3 years after that article was published, we had in our hospital in New Brunswick a protocol that every trauma patient that was admitted to the ICU was on a ketamine drip. That was in 1999. Not for sedation, for analgesic purposes. It's taken us 17 years to start getting literature to show that that's what we should be doing and what's the evidence around it. We're going to go through some of that literature just to see if we can expand your horizons a little bit, but also to make you aware. So I want to ask a question before I go through some of these articles. How many of you are using ketamine as a single analgesic? Neil, a few others. How many of you are using it in addition to an analgesic? A few more. So there's 2 studies only in the literature that have looked at ketamine in the emergency department as a single analgesic, and they were both published last year. Everything else has been combined with morphine. Can we reduce the amount of morphine? Can we reduce the dose of morphine? These 2 articles were published. And it's funny because both authors try to suggest that ketamine is a great analgesic, despite the fact that their data says it isn't, for different reasons. The 2 studies there are they're the Pitchfork study, which looked at kids, intranasal ketamine in kids, and the Sergei Motov study that came out of New York that was published in the Annals of Emergency Medicine. The Pitchfork study used a dose that is a bit problematic. If you give 0.5 milligrams per kilo intranasally of ketamine, you get very mixed results, and only about 40 to 50% of the children will get a decent analgesic effect. The problem is if you give 1 milligram per kilo, the rate of adverse effects starts going up. Ketamine is not a readily titratable drug because how does it work? It wears off by redistribution into fat. So if you give a little bit, then wait 15 minutes, and give another little bit, then wait 15 minutes, it disappears. So it's not a readily titratable drug. You sort of have to give the dose you want and then maintain it with an infusion. It's not something like opioids where you can titrate, it's more something you have to give and then a baseline infusion, just because of the way it's metabolized. So in the Pitchfork study, they compared 1.5 mics per kilo of fentanyl versus 1 milligram per kilo of ketamine, both intranasally. All children got 10 milligrams per kilo of ibuprofen. Okay? In the Motov study, it was 0.1 milligram per kilo of morphine over 3 to 5 minutes, which is a low dose of morphine, versus 0.3 milligrams per kilo of ketamine. So it was a high dose of analgesic dose ketamine versus a low dose of morphine. So they sort of stacked the deck a bit. So what did they find out? They found out the intranasal method with the pitchfork study was effective out to 60 minutes, with satisfaction higher in the ketamine group than in the fentanyl group, which really surprises me because I've been using aerosolized with a little syringe, the aerosolized fentanyl for probably about 6-7 years. And all I get are kids with goofy grins whose fractures no longer hurt them. And I give a second dose of fentanyl 15 minutes after the first, and I can actually reduce fractures in kids. It's like procedural sedation through the nose. And so I'm really surprised that ketamine had a higher satisfaction rate than fentanyl, because most of the kids I give fentanyl to have a very high satisfaction rate. The adverse event rates, however, were 78% for ketamine and only 30% for fentanyl. In the IV study, it was pushed too fast. It was given over 3 to 4 minutes, which in my experience is too fast. You have to give that 0.3 milligrams or 0.2 milligrams per ketamine over 10 minutes, or you get too much dissociative effects, too many side effects. And again, they had about 75% adverse event rates with their ketamine. Now they say it was minor, and their study says it was very minor adverse effects with ketamine, but it is not my experience clinically. And it's certainly not the experience in the literature. The literature says if you push 0.3, 0.4 milligrams per kilo over 2 or 3 minutes or faster, that you get people saying things like it was a horrific sensation. I felt like a zombie. My best comment 2 weeks ago was from a 72-year-old lady, and yes, she was too old. I shouldn't have given it to her. But she came in with CRPS, and I wanted to treat her pain, so I gave her the bolus over 10 minutes. And the nurses come running to me. I go over, and I felt like I was in Sixth Sense, because the woman says to me, "I see dead people." That's not what I intended. Now, fortunately, a milligram of midazolam and it went away. But there are things you have to be wary of. And so I think we're finding that ketamine is an excellent analgesic. I've been using it for 20 years as an analgesic, but there are some adverse effects. You can't give that initial bolus quickly. You have to give an infusion. And what's surprising is more is not better. I have routinely given 5 to 7 milligrams of ketamine IV, which is like almost sort of like, geez, I open the bottle and let them sniff the vial, and they get better. You don't have to use a lot. 0.1 milligram per kilo, 0.2 works just as well in my experience as 0.3 with less adverse effects. You then have to follow it up if you're going to give it for something like a broken extremity or something, and you're going to admit the patient with an infusion, and that's where you run into trouble with the gods of administration. What do you mean you're infusing ketamine? Well, that requires a monitor. That requires an ICU setting. You can't go to the war, and then the battles start. Because my nurses are very willing to let me push ketamine, and as soon as I say, well, let's continue with the infusion, they have to be in the monitored bed area. Okay. And it's been a battle to try and get that changed. So, number 3 looked as well at 0.5 milligrams per kilo of intranasal ketamine for children. Less than 50% had good pain relief. So it is not an effective dose. So you're sort of stuck with, if you're going to use intranasal ketamine, and it works, believe me, it works, that there are going to be some kids with adverse effects. What about for vaso-occlusive crisis? There is some literature that suggests that as a single agent, ketamine is not very good for vaso-occlusive crisis. This article, number 4, however, said we gave high-dose morphine, it didn't work. I don't know how it can't work. I can make morphine work on anybody. I just have to give them enough. Now, they may not be talking, and they may not be breathing, but I can always take away their pain with morphine. So I never understand studies that say I gave morphine and it didn't work. It then comes to the question, are they asking the right question? Morphine does not take away pain. Morphine means you just don't care about your pain anymore. How many of you have given morphine to someone with renal colic, they fall asleep, the nurse wakes the patient up, and they say, what's your pain scale? Why would you wake a patient up to ask them their pain scale? I don't understand, but it's part of the nursing mantra, and the patient's like, and falls back asleep. How many of you have seen that? Right? Why? because morphine doesn't take away pain. There was actually some great descriptions from the Vietnam War where the soldiers who were giving intramuscular morphine in the field before they were evacuated said it was like there was two soldiers and it was the soldier beside them that had the pain. It's not they didn't feel the pain, they just didn't care that they had it anymore. So I'm wondering if when they say it didn't work, they're asking the wrong question. What's your pain scale? Never ask people who are getting morphine what their pain scale is. It'll always be 8 or 9. Ask them, do you want more medication? Because they don't care, so they don't want more medication, but the pain scale is still high. In this study, number 4, when they said the morphine failed, so it had a fair amount of morphine, they gave ketamine 0.2 to 0.25 milligrams per kilogram per hour, which is the same thing as I recommend, accompanied by a very low dose of midazolam to prevent any adverse effects. And they said it allowed a decrease of 30 milligrams per day in total morphine dose with far better pain control. Now, I don't know what you think of a 30 milligram decrease in morphine, but I know what I start with in some of my patients with sickle cell disease. I start at 2 to 4 milligrams of hydromorphone. So I start at 20 to 30 milligrams of morphine equivalent. So if they're getting that every 2 or 3 hours, that means they're getting hundreds of milligrams of morphine equivalents in a day. So I'm not sure what decreasing it by 30 means. I do take note that consistently, study after study, morphine with ketamine, they seem to get better analgesic control. I'm not so worried that they get less morphine, but the fact they get better analgesia is more important to me. Number 6 and 7 say the same thing. Combination gives better pain relief while using less total opioid. Note now, however, number 6 only gave 1 5 milligram dose of morphine before randomizing to morphine or ketamine. And the median extra morphine dose required was 15 milligrams. So the average person in this study with severe pain required 20 milligrams of morphine in a morphine arm. Remember that. For example, number 7, 0.1 milligram per kilo. So I'm a 70 kilo person, the average size person. Actually, I'm not. I'm 100 kilos. So if you give me 7 milligrams, or the 0.1 milligram per kilo is a 70 kilo person, but the average required in this study before it was 20, then clearly you can see that in a study that compares 0.1 per kilo to ketamine is not being fair. If the average person required 20 and you're only giving them 7, then it's a straw dog comparison. It's a straw man comparison because you're not giving the right dose of morphine and yet saying, oh look, ketamine in the right dose works, but we give an inadequate dose of morphine, it doesn't work. And I think number 7 and number 6 are good studies to let you know that you titrate morphine and that 0.1 per kilo in at least 50% of patients is an inadequate dose. And you have to keep going back to get them where they need to be. So let's move on to something that I don't think we are cognizant enough in the emergency department, and that's ketamine and palliative care. Any of you do palliative care? One? Do you use ketamine? No. So ketamine and palliative care has been used for probably 15 to 20 years now. It's a great drug in palliative care. They start at very low infusions. They're usually subcutaneous. They often don't have IVs in palliative care. And what this drug does is it decreases opioid usage, which does multiple things. The patient's more awake. So they're much more able to converse with their loved ones in the last few days of their life, which many of them appreciate and the families appreciate. They're not zonked out by their medications. So they get the ketamine, they decrease the total morphine dose. The dyspnea associated with high dose morphine is gone. The ketamine takes that away completely. The hyperalgesia that you get with high dose opioids, if you give people more than a certain dose, about 30% start getting this burning pain all over their body and it hurts more and more the more opioid you give. Well, if you can decrease the morphine dose and give them ketamine, that hyperalgesia disappears. So the discomfort caused by high dose opioids in a palliative patient, the dyspnea, and the somnolence are all resolved by having ketamine as part of the armamentarium. So it is a very good drug. Yes?
Can I ask the dosage that you're using?
Yeah, it's there, and they start at very low doses. If you're at more than 0.1 milligram per kilo per hour, I'd be surprised. The doses in this study, 0.05 to 0.08 milligram per kilogram per hour is a starting point. They're very low doses, and that's been my experience for lots of people with chronic pain. be it cancer patients, be it fibromyalgia, or be it CRPS, they actually respond well to lower doses than people with acute pain. CRPS patients, fibromyalgia patients, I routinely give them 0.1 milligram per kilo push and then a 0.1 milligram per kilogram per hour IV infusion for 4 hours. The palliative care patients often do well with even lower doses than that. They're very low doses. And subcutaneous infusion of ketamine is just as effective as IV. You know, you see all these, yes, same dose. It's, you know, you see all these movies on TV where someone in an action film comes up and stabs someone in the neck and gives them an injection and they're unconscious, right? And you know no such drug exists like that. There are actually 2 or 3. Ketamine, 2 to 3 minutes IM and you're done. Midazolam's almost as fast, and of course succinylcholine. You give succinylcholine IM, you're done in 3 minutes. It's not a great sedating drug, and you might be panicking while you don't breathe, but it does work in 2 or 3 minutes. All right, so ketofol. Any of you using it? The shame with ketofol, it was done the wrong way. When it was first described in the literature, there were 2 articles published. They put milligram per milligram equivalent in a syringe. So they took 5 milligrams per cc of ketamine mixed with 5 milligrams per cc, because it was each has 10 milligrams per cc. So when you mix them together, it gives you 5 milligrams of each per mil. The problem with that, it comes back to what I told you earlier. You can't titrate ketamine. So what you're doing is you're titrating the propofol and you're getting whatever dose of ketamine you get. That's not what you want to do. What you want to do is give a dose of ketamine and then titrate your propofol. It's been shown, there was a study by Messenger out of Kingston in Canada that showed that if you give ketamine with propofol versus fentanyl with propofol, the oxygen saturation rate drops from about 70% to only 2 or 3%. So it's a much safer combination. So what you have to do though is you give your analgesic dose of ketamine, 0.3 milligrams, and some studies do 0.5, and you can give it push. You don't have to wait, because you're going to give, as soon as it's pushed in, you're going to give your first 20 milligrams of propofol. So you give the ketamine, then you give 20 milligrams of propofol, and that prevents them from getting the dissociative effects. And then you just titrate 20 milligrams of propofol every 45 seconds, which is 1 heart-brain circulation time. And you will find that if you need more than 2 or 3 doses of propofol, I would be astonished. You see lots of studies that say we started with 1 milligram per kilo of propofol. That's way too much in elderly people. They stop breathing. They desaturate. I've routinely given people 0.2 or 0.3 milligrams of ketamine per kilo. And I give them 20, maybe 30 milligrams of propofol in the elderly, and they're gone. Nowhere near 1 milligram per kilo is required. So you titrate your propofol to effect with the ketamine given at first. And you'll be surprised how little propofol you need. And there's a great way to know when you need to get there. When you give propofol, they do one of 2 things. They either rub their nose or they start grinning. And that means they need 1 more dose of propofol. It's really remarkable how they do that. All right. Ketamine is a drug that works fast. Managing adverse effects of ketamine. Number 12. Looking at IV or IM ketamine in dissociative anesthesia doses for fracture patients in adults less than age 50. So what they did was they randomized to midazolam, about 2 milligrams in average person, or placebo. And they found that if you gave ketamine alone, agitation at recovery was 25%, but if you gave midazolam, it was 8%. If you give the 1 milligram or 2 milligrams of midazolam, they don't get sedated. It doesn't prolong your sedation time, but they wake up without the agitation. I have a cutoff. It's basically when you have pubic hair, you get midazolam. That to me is the definition of the end of childhood. Unlike pediatrics, who thinks you have to be 18 before you stop being a child, my definition is you have pubic hair, you're no longer a child. And so I just routinely give 1 milligram. I only give 1 milligram. If you don't want to give something routinely, just wait and see. They start getting a bit agitated or a bit antsy as they're waking up. Just give them 1 milligram of midazolam, it'll all go away. And there's this reference is there, number 12, that shows that it works It consistently reduces the risk of agitation. There is sort of a cutoff, however. Somewhere around age 55 or 60, the rate of agitation almost goes up exponentially. And elderly people don't wake up well with ketamine. Elderly people seem to have more nightmarish feelings, more agitation. I had this one woman wake up and all she did was go, ooh, for 2.5 minutes. I started wondering, is this a bad waking up? Or is this a good waking up? Because you only say that there's this agitation when you wake up, but it doesn't mean it's necessarily bad. So I couldn't figure out if she was feeling bad or feeling good. And in fact, 20 minutes later, she told me, I don't know what you gave me, but I felt great with that drug. I'm thinking, so cooing for 2.5 minutes was good for you. And, but it was. But I've seen more elderly people get bad effects, nightmarish effects. And so once you hit about 55, 60, I start getting reluctant to give you ketamine, even if I do give you midazolam. Have any of you else had that experience? Do you give it to elderly people? Anybody? No? Just kids? All right. Hypersalivation in children, number 13. This is sort of, don't be sure you want this. This was, they talked about, because you used to say, well, with ketamine, you always have to give atropine to prevent hypersalivation. So they gave 0.01 milligrams per kilogram. But remember, onset of ketamine IM is 3 minutes. Onset of atropine IM is 40 minutes. So either have to give your atropine 40 minutes before you give your ketamine, or you have to give them the ketamine, stick an IV in, and give them the IV atropine. But you can't give the two IM together because the patient will be going home before the atropine starts working. So you have to remember that. So it did decrease the rate of hypersalivation from 28% to 12%. So yes, it did do that, but it decreased the suction rates from 21% to 4%. So a big improvement. But crying and thrashing were more common in the atropine group, 12% versus 2%. So would you rather have the child scream and thrash or drool? I know what my answer is. They can drool just fine because the parents get upset when their child's screaming and thrashing, okay? Don't forget, drooling's not a bad thing. It's the drooling that then leads to laryngospasm. How many of you had a child get laryngospasm from ketamine? One? How many? Just once? I've probably given it several thousand times. I've had it happen once. It's a rare event and you can bag through it. But to have 12% of my kids thrashing and agitated, I'd rather not have that. Finally, just so you know, yes?
Most of the time they drool just for a short period.
Yeah, I agree. It's minuscule. I don't treat the drooling. I just let them go and I just change their chin position and I don't worry. I agree. I think it's a minor problem. To finish up, there is some neat stuff going on in ketamine. And that is to let you know that for CRPS, complex regional pain syndrome, which used to be RDS, they're now looking at studies. There was a study out of Germany that showed if you gave a 96-hour infusion of ketamine, very low dose, people with CRPS were pain-free for 6 to 8 months, required no medication whatsoever, none. 0.1 milligram per kilo per hour for 96 hours. There is now 2 studies in Canada. They're looking at giving it 4 days in a row of 6 to 8 hours in infusion instead of that 96 hours in a row, and they're getting exactly the same results. So it seems like one of the ways to treat CRPS in the future is no medication at all, except 4 days every 6 to 8 months you get these infusions. And I bring that up because if you see somebody with CRPS in your emergency department who's in agony, don't give them opioids. They don't work. They're not recommended. Please give them the ketamine. Give them the dose we just talked about, 0.1 to 0.2 milligrams per kilo bolus, and then a 4-hour infusion of ketamine. Because what it does is it resets their NMDA receptors. Their acute flare period, which lasts 2 to 3 weeks when they get a flare of their pain with CRPS, is cut off. They go back to baseline pain. So 4 hours of ketamine in an emergency department, their flare of 3 weeks severe pain is done. They go back to baseline. Ketamine is becoming increasingly the drug of choice for CRPS, and I just want to bring that to your attention. Any questions? Yep.
So have you any evidence to show same doses, 0.1 milligram per kilogram in your migrainous patients, particularly these are coming, with frequent migraines.
So the question was, is ketamine in those same doses good for migraine patients? And the answer is, the studies are very weak right now. The problem with any migraine study you do, you have to follow the patients to show what happens at 24 hours. For example, if you give sumatriptan, it works 70-80% of the time, but you have a 47 to 48% recurrence rate at 24 hours. So it's not a very good drug for most patients. The ketamine studies have said, we had a bunch of people, we gave them ketamine, their headaches got better. But they don't follow the patients, know what they're like the next day. So I don't know what the headache recurrence rate is. I would tell you if your usual drugs don't work, it is an option you can consider.
Can I ask one more question?
Sure.
Just about, I've seen what you say about if patients with coming with renal colic, you give him ketamine, maybe works quite well, but some of those getting morphine, you wake them up, I still have the same pain. What about in that case is using the same dose of ketamine?
So the question about, instead of morphine, giving ketamine for renal colic, I'm sure it would work, it's just never been studied. I'm sure it would, but I don't mind that people have pain that they don't care about. With morphine, that doesn't bother me at all. One last, yeah.
So you talk about 1 milligram per kilogram IV over 10 minutes as a bolus and then infusion. Is there a ceiling? Is there a
Probably the upper limit, so about the ceiling of dose for ketamine, all the studies go between 0.1 per kilo as a bolus to 0.3. Yeah, once you get above 0.3, you start getting too much dissociative effects, and so the ceiling isn't because you don't get better pain relief, but you get more and more dissociative effects. That's why that ceiling is there. Last question?
Agitation. Are you using it for agitation?
Am I using it for agitation? I have to admit, if it's a agitated patient that I don't think is psychotic, I use it. In a patient who's psychotic, I'm always concerned I'm going to make their psychosis worse. But yes, I've used it. It works really well.